Well, thank you. It's a pleasure to be here today. I've had the joy of working with Kevin and many of the other individuals that have spoken to you over the last several hours. What I'd like to do today is to take us a step back, looking a little bit more holistically at what the state of medicine is and what the state of assessment is within medicine. And I would start by stating that the essence of precision medicine is precision measurement. And that begs the question of what, when, and how we engage the human organism in real time under perturbable situations to begin that kind of assessment. So let me take you on a journey that I took over the decades that I have been involved in clinical medicine, and where I decided it was time to begin to invest in the concepts that I just described to you. So let me start with a journey. Many of you came here today in an airplane. You walked into that airplane this morning, you looked into the cockpit, and there were hundreds of lights that monitor the internal and external environment of that airplane. Let's think about that as an organism. And you were very pleased by that fact, as I would be. Now, when you go home tonight and you walk into that same airplane and all the lights are off, and you walk in and say, well, why are the lights off? And they say, well, we only turn these lights on every 6 or 8 weeks. In medicine, for our sickest patients, never mind those of you that simply go for your annual physical, but for our sickest patients, we only turn those lights on every 6 or 8 weeks. So as a result, we lead our lives daily under perturbable situations, but from medicine's point of view, you're a date on the calendar for your annual physical or your 2-month or 3-month physical. And what that has led to for the last 75 years, since organized medicine really began to achieve many of the good things that we know of today, is that our real-life assessments outside of the doctor's office don't occur. Medicine has become episodic and reactive, and as a result, we do a good job of focusing on diagnosis of disease and progression to morbidity, mortality, and death, but we don't understand the gold standard for our profession, which is wellness and its progression to disease. And the system itself, because of this loss of detailed content and continuity, does not allow us to build these kinds of assessment tools. Now, I am pleased and proud to have been part of the Human Genome Project. I helped set up the Broad. I was on the board of directors of the Broad until I retired a few years ago. And much of the promise of the human genome was to solve the problems I just mentioned. All we need is the book of life. By the way, we invented a book we couldn't read at the time, but we began to learn how to read it. But once we learned how to read it, the argument went, all life would be solved, and we could intervene diagnostically, therapeutically. Well, there have been some successes here. I give you the example of cancer, much of which you heard about today, and I would posit by saying that cancer is unique in that 95% of cancers, as you all heard and many of you know and work in, present with a somatic mutation. We know it's a lot more complicated than that, but at least there's a guiding light to initial therapy. And I show you an example here of where the power of that information can be utilized in the rapid deployment of a therapeutic. This was unique for me because I sat with 2 hats. I was the chairman of medicine at Mass General, where I watched my cancer center interrogate a mutation in a small subset of non-small cell lung cancer, and I was the lead director at Pfizer, who at the time, in the mid-2000s, had developed a drug that was going to be marketed like almost all drugs, generically across non-small cell cancer, largely because it was a good MET inhibitor. We put the two groups together, and at 2007, with the demonstration of the importance of the ALK translocation, 2009, the first report that crizotinib was a potent drug in this scenario, to 2011, a 4-year time span for the approval, FDA approval of a drug. Now, most of you know in this audience that the average development time is 12 to 14 years. If we could do this in more fields, we would be astoundingly successful, even with today's knowledge. The problem, of course, that I see, and the one that I'm working on, and why we're here today, is that our ability to generalize this paradigm to chronic diseases remains very limited. So for heart disease, we have a whole host of hardy perennials that most of you are familiar with that provide risk assessments for cardiovascular disease: age, sex, smoking, cholesterol, blood pressure, diabetes, family history, all of the things that we'll talk more detail about a little bit later, perhaps in the panel. And from these assessment tools that have been around since the Framingham study began in the 1940s, we can build an assessment tool for risk. When we add, as of 2015, all of the genetic information that we now know, et cetera, many are common variants, we don't gain much, simply with genetic variation. Now, the reason for that is it's a heterogeneous group. I could do the same thing for type 2 diabetes, with the GWAS studies having 120 now to 150 common variants associated with the disease, but they are no better in 2016 than our clinical assessment tools are. As a matter of fact, for cardiovascular disease, as you'll hear from the experts later, as important as cholesterol is, probably 35 to 40%, an enormous impact, as many as 50% of individuals having a first cardiovascular event have 0 or 1 of the traditional risk factors. Now, why is that? It's largely because of the absence of measurement of things we're only now beginning to work on: pathways of inflammation, the microbiome and its contributions. I'll tell you a little bit more about that, and hopefully you can interrogate us as a panel later. So, what is this measurement gap? Not to downplay the importance of genotype, but the true measurement gap is to fundamentally understand holistically phenotype, the interaction between genotype, behavior, and environment that ultimately contribute to the readout of the human condition, which of course is proteins, fatty acids, and a variety of other compounds that dictate how we behave in real life under perturbable situations. And we still have a long way to go of bridging this gap. And for those that think that the genotype is immutable, which is the way my generation both learned and, quite frankly, we taught, keep in mind that the epigenome in the immune cells, for example, can change in 48 hours. 48 hours. So we no longer look at the pathway that our body is responding as immutable linear pathways, but complex engagements. And our ability to fundamentally understand that degree of complexity will ultimately come back to our ability to homogenize, subpopulate, stratify, and therefore develop an opportunity for a more finite therapeutic intervention. You've heard many of these statements earlier today surrounding syndromes and how do we deal with the complexity of syndromes, neurology, of course, being the poster child for that. But even in cancer or in heart disease, or certainly in the area that I work in, obesity and diabetes, the word diabetes will be 10 diseases in many of the younger people's lifetimes here. Hopefully mine, but certainly yours. It will go the way that apoplexy went 100 years ago for cardiovascular disease. And you'll be talking about abnormal gluconeogenesis, abnormal fat cell inflammation and injury, microbiome engagement of Treg regulation, and innate immune changes in inflammation, et cetera, et cetera. Now, the only way we're going to get there is to measure better, measure more often, and measure more smartly. And I'd like to show you how the pathway to achieve that we can go forward. The reason this becomes important is that we generate a lot of data in medicine. And the genome is only one piece of that. It certainly was the poster child for generating the concept of big data, but we have big data at every turn. You just have to take an electronic medical record. Much of our big data is non-structured information, but that non-structured information ultimately carries a wealth of identity of what the personal readout is and where precision medicine is. We need an integration system in medicine so that we're not just generating data, but we're generating data that leads to knowledge that's actionable. And that is a huge hurdle today in medicine. And what we're building now is that the concept that phenotypic measurements will be key enablers of all aspects of the design of this kind of interrogation. The scientific investigation that allows us to align everything from the basic science in an iterative way with real-world patient care to ultimately the clinical investigatory activities of developing subgroups, disease biomarkers, and ultimately therapeutic diagnostic and therapeutic intervention. And so what we need, as I'll show you at the end, is this knowledge integrator, and that is still in its infantile form. Now, the other big problem with phenotyping is that it is largely reserved to the elite. Large activities, such as large academic centers that I belong to, big clinical research centers, large consortiums. But it's divorced from patient care for the most part, and therefore has limited scalability. How are we going to get at not the few or few hundred that we can do this on with robustness at a place like Mass General or the Brigham or Harvard Medical School, where I've worked all my life, but out there, everywhere, City of Boston, the United States, the world. That needs to be defined. So 3 years ago, when I stepped down as chairman of medicine, I started this program that Kevin alluded to called Center for Assessment, Technology, and Continuous Health, CATCH. I was the best third-string catcher Harvard ever had, so I had to get that term in there somehow or other. In that context, we built it upon the concept that I alluded to earlier. It's all about measurement. It's about how continuous our measurement is, and continuous is only in the eye of the beholder. In some cases, it can be every second or minute, as you'll hear about devices later. In other cases, it might be the novel measurement once a week of an inflammatory marker that had traditionally never been measured before. It's about behavioral measurements, which include all the things that we do right and mostly wrong: our diet, our exercise, our sleep, and a whole variety of others, our medications, etc. It includes the antenna within the body for environmental responses. And I'll use the microbiome as the poster child for that, which has only recently become a universally new organ that not only interrogates and has its antenna on the external environment, but we now know intimately regulates T-cell regulation and the immune system and ultimately inflammation, and is beginning to provide, for example, some of those biomarkers that I said were unknown in inflammation and injury in cardiovascular disease. And then, of course, there's the traditional measurement, the one I grew up with as a molecular and cell biologist, which is the pathway-inspired measurement. That isn't going away. The rigor of that science is still valid, but it requires ultimately a holistic assessment toolkit under these perturbable real-life situations. Now, needless to say, in the 10 minutes I have left, I don't have time to go through all of these in detail. I'm happy to answer any questions, but I'm going to give you 2 examples of studies that we've undertaken. The first is in behavior, largely because, as all of you know, in type 2 diabetes, the best drug we have in 2016 is lifestyle change, better than anything else we can do for early onset diabetes. And it's a function of behavioral assessment and behavioral measurements. So what we did is we decided that the best medical tool ever invented was the smartphone. Now, it wouldn't be used as a medical tool if it was invented as such, but it is such a common purveyor of information and its growing reliability and assessment that using the cell phone for not only for active engagement, but for passive engagement has become a real utility in developing these kinds of scalable information sets across a wide range of demographics and patients. And I won't have time to talk to you about all the things we've done. We've worked very closely with the Media Lab and Sandy Petland just across the street here at MIT. And we can begin to look at simply the nature of the conversations, not what you say, but who you call and when you call. And we were able to diagnose disease 2 weeks before onset in students at MIT. Turns out they only call their mother every 6 months, and suddenly they called her every day for 2 days. They developed the flu shortly after that. So there's, I guess, a lesson to knowing when mothers are important. We were one of 5 groups that were able to convince Apple to develop the research kit. And again, I'll only give you a glance at this, but our program was, again, diabetes. It's called Glucose Success. Stan Shaw, the co-director of CATCH, was selected to develop one of the first 5 clinical applications. There's nothing particularly magic or an epiphany about this, but it is integrated in a way that doesn't simply give information back that patients already know. For example, how many of you are wearing a Fitbit today? Okay. How many of you used to wear a Fitbit and don't wear it anymore or don't use it? The statistics are that about 90% after 6 weeks stop using it. The major reason is that it's giving you information you already know. You know when you've taken 10,000 steps or 100. What really will work in minimally invasive and minimally intrusive assessment is the gee whiz phenomena. Wow, I didn't know that if you take A and B and put it together, or in some other combination, you can give me a set of information that will allow me to assess my behavior and hopefully improve upon it. So again, without going into detail, we were able to start the research kit with Glucose Success. One of the most important aspects of this for the future is that within 36 hours, this is an IRB HIPAA-approved asset with 1 click. It took us 2 years to get 5 institutions to agree on a common IRB. Apple was simply the purveyor of the hardware here. They are not particularly interested in research. They're interested in selling commodities. Nothing wrong with that. They do a good job at that, but they simply wanted to be a facilitator. So with 1 click, you're enrolled in a clinical study, and 135,000 people in 6 days signed up for these kinds of studies. There was one on the heart at Stanford. There was one on asthma, one on neurodegenerative disease, et cetera. And the power of that I cannot underestimate. If we were going to do a clinical trial, a big clinical trial, big, tens of millions, hundreds of millions of dollars, maybe $1 billion over a 5 to 7 year period, might be 10 or 20,000 people. Might be. That would be huge. In the context of having hundreds of thousands of people, one can interrogate much more briskly, anonymously if you choose. So in that context, we found several subtypes of glucose control. We reiterated and was able to show that everybody that used the app actually improved their blood sugar on a daily basis, and that we were able to show that exercise on day N-1 lowered the blood sugar, a milligram and a half fasting blood sugar the next day. Now, this doesn't sound like a profound statement. We did this on 300 patients. We've now done this on 3,000 patients. The largest single study preceding this on exercise and diabetes, something I think we all would take for granted, was 75 people. A clinical trial of 75 people. So the ability now to look at what subsets and of these groups, they were outliers, and many times, as those scientists in the room know, it is the phenotypic outliers that give you the most information for interrogating pathways. So, behavioral assessment tools, ultimately that will lead to readouts, to stratification, are going to be important. What about the environmental response that I alluded to? Well, again, all of you, I'm sure, are now familiar with the microbiome, but I would say 10 years ago, less than 1% of this audience would have been. Microbes, as you know, outnumber us 10 to 1. They collectively have 8 million novel genes. 8 million novel genes. Remember, the human genome is about 25,000. There are about 10,000 species, more or less, and we're all walking around with about 5 pounds of these little buggers. Not a good way to lose weight, however, I can tell you that. We develop, of course, we're born sterile, but depending on the birth route, our genetics, hygiene, diet, drugs, and other environmental factors, over the first 2 or 3 years of life, we develop a complex and stable microbiome that we now know is an antenna to the external environment, which includes diet, drugs, other environmental elements, and can regulate the innate and adaptive immune system. However, at any point in time in life, we now have an enormous number of examples where dysregulation or dysbiosis can cause and is implicated in disease. Now, some of these may be obvious to you. Inflammatory bowel disease comes to mind. That seems to make sense. I chose one, however, that I doubt anyone in the audience who's not in the field would have picked: type 1 diabetes. Now, type 1 diabetes is an autoimmune disease. Ron Xavier and his colleagues, the head of the GI unit at Mass General, looked at an HLA selective group in Finland where there's a high incidence of type 1 diabetes, although not predictive simply based on the basis of HLA sensitivity. And early in life, within the first several months of life, there is a significant change in both the diversity, as shown here, in the microbiome, but in the products for which they synthesize and release and interrogate a series of receptors. Short-chain fatty acids, for example, interrogate it turns out, orphan olfactory receptors, which now we know can regulate Tregs, for example. What's incredible, however, is that understanding this diversity and the biochemical diversity that results from that, Romnick and his team was able to predict in a group who was going to develop type 1 diabetes before they became seroconverted and hyperglycemic. Simply with no other information about these individuals other than microbiome diversity and pathway specificity. Now, you can see the beginning here of a powerful new annotation and assessment tool for a completely new organ called the microbiome. Now, in this context, as I said, ultimately we want collective assessment of these kinds of tools. Some will be more important in certain disease states, but they all will be important in understanding wellness and ultimately its progression to disease. And a few years ago, we put together the concept of precision medicine for the National Academy that I had the privilege of participating in, and I don't think much has changed since then about generating this knowledge network that is an information's commons. And it goes from the patient to the exposome. Everything has to be omic, of course. The exposome is the environment that you and I live in. But we now can begin to annotate and collate the signs and symptoms of disease which were largely left outside of the concept of precision medicine in ways that can be looked at in relationship to biomarkers, the protein markers that we said were important, metabolites, whether it be the microbiome metabolites or circulating metabolites, and ultimately integrate that into a sophisticated, thoughtful assessment tool for where a patient stands on this progression from wellness to disease. More importantly, or at least equally importantly, is our ability now to develop this kind of quantitative continuous assessment tools leads to novel phenotypes that ultimately, when combined with genotypes, leads to this stratification that becomes important. Most of you understand, and many of you participate in, that as many as 30 to 40% of phase 3 clinical trials in the United States fail. Not because of the occasional one that you read about that's killed people. Most of them fail because of lack of efficacy. And the reason you have lack of efficacy is the same way that we had lack of efficacy with cancer drugs when they were getting 18 or 19% across a disease that we called non-small cell lung cancer. But when we began to stratify, i.e. EGFR mutations, ALK translocations, we got 95% response. The same will now become true in diabetes, cardiovascular disease, when we can begin to stratify subpopulations, so we're no longer dealing with a syndrome, we're dealing with subsets that have homogeneous characteristics, and therefore both diagnostically and therapeutically will have a much higher rate of success in our development of either of those toolkits. So my plea, and I think where the future lies, is we need a renewed focus on phenotypes. We must measure it with the same precision that we expect today of our molecular and genetic information. We need it in real time to provide a perpetual readout. It needs to be in the context of multiple perturbations, such as the way we live our daily lives, and must ultimately create actionable new knowledge for healthcare performance. Notice I used the 4 Ps here, a la Leroy Hood, but in a different context, okay? Equally important, we live in an era now, and my generation of physician did a good job of telling our patients what we knew about a problem. We've done a lousy job of telling our patients what we don't know about the problem and how they can help us. So not only do we need to make our patients partners in clinical care, that's a common phenomena today that all of you are experiencing, but we need to make them partners in discovery. Because at the end of the day, they are the repository of the kinds of information that will become this sophisticated annotation of wellness and disease. So we need this partnership. We need it to be engaged and participatory. We need two-way information, so we're both learning. It needs that the patient should own everything, and I can come back to that if anyone is interested. And most importantly, and I think this will be true in the United States if we can achieve it, we need to unify wellness with the spirit of inquiry. We need to tell our patients that interrogation, even when they're healthy or when they're perceived to be healthy, is an important component of how we're going to learn going forward. And I think in this context, this kind of partnership will be robust, it will be scalable, and ultimately it will provide the kinds of tools and skill sets that we think will be necessary going forward. So with that, I thank you for the opportunity to talk to you today.